So we would like to start the interview by introducing ourselves. This is Dr. Bear.
Yes, I'm Dr. Bear, the Catholic University. Now I'm the Secretary General of the Castle 2018. Nice to meet you.
And I'm Seung-Won Lee from Catholic University of Korea. I'm working with Dr. Bear as a hepatologist. And please introduce yourself briefly.
I'm Dr. Jidong Jia from Beijing Friendship Hospital, Capital Medical University. I'm a clinical hepatologist. I used to work as the president of APDW. Also worked as the president of International Association for Study of Liver Disease. So very nice to be here to have the conversation with both of you.
So you're giving the talk on two topics, HPV and HCV co-infection and cholestatic liver disease. So we'll start with the co-infection of HPV and HCV.
So I want to ask you your main focus of your lectures in the co-infection of HPV and HCV.
Well, actually my talk includes three parts. The first is a brief definition of the so-called co-infection, or we say maybe dual infection, and a little bit about the epidemiology. Because this topic is especially relevant in our region because both hepatitis B and hepatitis C are relatively prevalent. So in co-infection or dual infection is not rare in clinical practice. Actually, if you look at the reports from our region, especially from mainland China, we can see around 4% of HCV patients also has HPV surface antigen positive. If you consider the so-called resolved infection or past infection, that means only positive for anti-core for hepatitis B, then the prevalence would be very, very high. So this would be a clinical concern in clinical practice in the era of anti-HCV DAAs.
Do you have data on also the patients with HPV? What is the prevalence of HCV in patients with HPV?
Well, of course, that's we have some studies, but the number change very greatly. I mean, because the selection of patient population, whether it's just from the health check, ordinary population, or those with liver disease, among those with liver disease, maybe the proportion is higher, around maybe 10%. They have infected both B and C. If you check the general population, or those come for health check, maybe only less than 0.1% are positive for both B and C. In those surface antigen positive, maybe around 1 or 2% also positive for hepatitis C.
So, according to the previous reports, when we treat the DAA for the HCV infections. After that, the reactivation of HPV. Some of them is the progress to the liver failures. So we're concerning about that, the co-infection. But do you have experience about at first the treatment of HCV by DAA and then really go to the patient, the progress to the liver failure? Do you have any?
No, personally I have know that because we from literature, we see even from a large group of patients, only very few of them really develop to the clinical decompensation or liver failure. Because in China, we just started to use all oral DAAs, so we still have just not big number of patients who experience that. But we do have from China report so-called virological reactivation or biochemical relapse. We do see that patient. But all the patients, because we found in time, we give antiviral therapy like entecavir or tenofovir, then the virus of hepatitis B were very quickly controlled. So no very bad clinical outcome occurred.
Right. I agree.
So what would be the clinical implication of HPV and HCV co-infection? Does it lead to adverse clinical outcomes?
Yes, that's true. Just as you mentioned, actually, these two viruses are very, very interesting. They can infect the same person. I mean, the live together but not very happily because they could inhibit each other. But in general, hepatitis C maybe have more effect of suppression on hepatitis B. Although there are some reports, hepatitis B could also inhibit the replication of hepatitis C. That's number one. But although they are inhibit each other, but the result of the liver damage actually is greater than any mono infection. So if the patient dual infect with B and C, then the progression to cirrhosis or HCC are much faster than infect either virus.
So we'll move on to cholestatic liver disease.
Yes.
Yes. You have a question?
So I want to ask again the main topics, comment, the focus on the topics. Could you say again?
I mean the
cholestatic liver disease.
Cholestatic liver disease. Yeah. Yes, cholestatic liver disease is a bigger term we use to describe all the disease with cholestasis. But as a clinical hepatologist, we mainly say that's about intrahepatic cholestasis. Because, of course, in clinical practice, we do see patients with actual hepatic cholestasis caused by stone, by tumor, by necrotic inflammation. That's more or less relatively easy to differentiate and to treat with either surgical, interventional, or endoscopic approaches. But what we really mean cholestasis, usually we refer to the intrahepatic cholestasis. Among them, the specific disease like primary biliary cholangitis, formerly called primary biliary cirrhosis, was regarded as a Western disease, but actually in the last 20, 30 years, we see more and more patients, just because maybe increased awareness and widespread use of autoantibody, especially for AMA-M2. So we see more and more patients in that. In China, there are several major centers have a lot of patients. In our single center, just recently we published a paper in a cohort about more than 700 patients. So that's a relatively common disease in clinical practice. Or in other words, we see it's a common disease. It's a how to say, relatively common disease among the rare disease.
Okay, you agree. So you say about the AMA-M2 subtypes, and did you the mitochondrial?
Yeah.
So did you check we always checked about just the anti-mitochondrial antibody, not subtypes in Korea. So do you need we need the diagnosis for the autoantibody negative autoimmune hepatitis disease? Do you need the subtypes of the anti-mitochondrial antibodies?
Yeah, I understand what you mean. In mainland China, we have both. We have the total antibody for AMA. We also have subtype. We have different versions. We have, but I believe, or the most literacy, AMA-M2 subtype is relatively more specific than the AMA total antibody. So for the diagnosis of PBC, then of course it would be better to test AMA-M2 subtype than just the total antibodies. Of course, we have other antibodies like SP100 and GP210. All this relatively insensitive but more specific. So they are usually we use as AMM2 plus these two antibodies. Try to increase to have a optimized sensitivity and specificity.
The final question regarding PBC. There are new pharmacotherapies in the field now. Originally we only had UDCA.
Yeah.
So do you have any experience on new drugs? Does it really lead to better clinical outcomes? And what is your opinion?
Well, for the PBC patients, UDCA had been the only approved therapy for many, many years until recently, orbitic acid, bile acid, cholic acid proved for the PBC in Western countries. Of course, in clinical practice, we do see patients who does not respond to the UDCA, maybe around 20–30% according different setting, according different criteria. It's Paris criteria or Barcelona criteria or different criteria. In that situation, we would say, according to different situation, we would add some phenobate or benzabate, or this kind of medications. This also gets improvement in some of patients. Because in sub-specific group of patients, they have the overlap syndrome. They have high IgG levels, high ALT levels, maybe, or have evidence of neck inflammation. Maybe we diagnose them with the overlap syndrome with AIH. That situation, add of corticosteroid or immunosuppressive therapy would be benefit. Then, besides that, then the oxalic acid or also offer some benefit either in combination with the UDCA or as a treatment monotherapy. But recently we know that the adverse effect like pruritus become, in some patients, can be very serious. And also some very serious adverse events. No, I haven't seen the full publication, but I did heard the report in just ended the ASLD meeting.
Lipid profile.
Yes, that's very, not only lipid profile, but also the very bad clinical outcomes. So obviously we need other new treatment for this, but still at a very early development.
So it needs validation.
Yes.
It's a promising therapy, but needs validation.
Yeah, maybe I think that this molecule need to be modified, try to keep his efficacy, reduce the toxicity or side effect. Maybe that's we need to expect.
I have one more question.
Yeah.
So we have the diagnostic criteria for the autoimmune disease or antimitochondrial PBC.
Yeah.
But there is a universal autoantibody, just FANA or just M8 or just SLA antibody. So, but some of them, about 10%, there is a autoantibody negative autoimmune disease or the PBC. So until now, the diagnostic criteria, there is a no additional antibody for the diagnosis until now. So do you think that we need the modified or for the additional antibody the tools for the revised the criteria, diagnostic criteria, do you think?
Yes, I agree with you. If there is some new markers, including autoantibodies, could be either sensitive or specific for PBC, as confirmed by other modalities. But at the moment, in clinical practice, we do see patients who are negative for all the available antibodies. But in that situation, we need to rely on the histopathology, which is very important. We need a very good pathologist who are really good at liver pathology specifically, not general pathology. We also see more and more patients with the so-called AMA negative PBC because we do liver biopsy in this kind of patients who have elevation of ALP or gamma GT but negative for these autoantibodies. Then if you do liver biopsy, you have very good liver pathologists, then it is very helpful to help you diagnose. But maybe at that time, we have the liver biopsy confirmed biomarkers or including autoantibody. Maybe we can revise the diagnostic criteria, as you mentioned.
With pathology, important.
Yeah.
Okay. Thank you very much.
Yeah, thank you.